right, we're going to move forward. The next speaker is Dr. Cristina Sadowsky from Kennedy Krieger. She's the spinal cord injury program director. She's not an ALD physician, but she's been seeing our AMN patients now for many years, evaluating their bowel bladder function, which is a common problem in spinal cord injury as well. So I'm glad she could make it today. Go ahead.
Hello, and as Dr. Fatimi said, I am not an ALD specialist. So when I walked in here and I was hearing all those smart talks about gene therapy, I figured that this is not the room that I'm supposed to be. But I'm going to burst the science bubble and I'll bring you in a more mundane bladder because, as John Lennon wrote in that beautiful boy song, life is what happens when you're busy making other plans. So bowel and bladder are kind of important. And that's, let's see, I'm going to put my glasses because I can't see it. Very small here. Okay, let's see. Well, I'm not going to bore you with a lot of anatomy, but I will mention some anatomy because Dr. Fatimi said that everybody could use a refresher. The bowel and bladder are controlled through the central and peripheral nervous system. I'm having a lot of things here on the computer. Connect uploads and stuff. So it's central nervous system and peripheral nervous system. We have the ability to voluntarily control most of the time, but then in certain conditions which are related with central nervous system CNS pathology, which ALD is part of it. ALD is actually part of both central and peripheral. We lose that ability to control. The anatomy, the actual anatomy is kidneys make the urine. The urine is being collected in the renal collecting systems. The ureters, which are the little tubules that are going from the kidney into the bladder, do not have specific sphincters closing, so that makes an important mechanical consequence. If there are increased pressures into the bladder, which we'll talk about a little bit later, there is the possibility of what we call vesicoureteral reflux, meaning backwashing the urine from the bladder into the kidney, which is obviously not something that from an infectious disease point of view is desired. The bladder is not a sterile environment, despite the fact that we've been taught for eons that our bladders are sterile. They're not. Then bladder has two functions. One is storage, and the other one is elimination. Storage is done under the influence of the sympathetic nervous system. The elimination is done under the influence of the parasympathetic nervous system. And we do have that ability to voluntarily control bowel and bladder function, and that is done through the somatic nervous system. So those are the general things. Am I? Okay, I am not able to make this move. I can talk without. Okay, let's go to the innervation of the system. I kind of alluded to the fact that we have the central nervous system, which is the one that actually gives you the input to say, oh, I'm going to hold it in and not leave the room right now, despite the fact that, you know, I need to. I can wait another 5 or so minutes. We have the autonomic nervous system, the sympathetic and parasympathetic, which is located in the thoracolumbar and sacral area that controls the storage and the elimination. And we have specific pathologies that occur where considering where the neurologic deficit is located. So ALD has neurologic deficits that are stemming from both the central and the peripheral nervous system. And because of that, I'm not giving you all of that information because it's way too much. Because of that, we have 3 different types of neurogenic bladder. The one is the supraspinal, the other one is the spinal, and the last one is the sacral pattern. They manifest differently. The supraspinal one is when it can occur in strokes, TBIs, and ALD with CNS involvement. And you have increased urinary urgency, inability to store, nocturia, which is frequency of urination at night. And that is similar to the spinal pattern, but there is a difference in between the supraspinal and the spinal pattern. The spinal pattern, which is when you have the injury that located into the motor neurons into the thoracic or thoracolumbar or sacral area, you have a discontinuity, a dysynergia in between the control of the bladder contraction and the sphincter relaxation. In order for the bladder to store, it needs to be able to expand, and it has a sphincter. In fact, it has 2 sphincters, the internal sphincter, which is under autonomic control. We cannot make it stay closed or open on our own, and then the external sphincter, which is under voluntary control. Well, in the spinal form of a neurogenic bladder, which is very common in individuals with ALD, we have a dysynergia in between the bladder contraction and the sphincter, internal sphincter contraction, which in turn leads to increased detrusor pressures, which in turn can lead to vesicoureteral pressure, vesicoureteral reflux, and backwashing of the urine into the kidney. So spinal and supraspinal have increased urgency, frequency, sometimes inability to start and stop, but there is that pathophysiologic difference in between the spinal and supraspinal that can only be identified, not clinically, by doing a specific study, which is the urodynamic study. The sacral kind of changes, the bladder is a bladder that has lack of peripheral innervation. So it's a big capacity bladder with inability to void, except if you do a lot of vagal pressure, except of effort. That is less likely to occur. But why am I putting all 3 of the patterns here? Because all 3 of them have been documented in a series of individuals with both ALD, AMN, and X-linked carriers. And the fact is that about 60 to 70% of individuals that have been tested do have bladder and bowel incontinence, specifically bladder incontinence. So maybe people just feel that this is natural progression or this is not important, but saving kidneys is quite important. Let's see. Okay, let's go to bladder symptoms in ALD. So something to take home. They're present in more than 75% of both males and female carriers. And that are actually in a related disease like MS, there is no difference in symptoms in between people with ALD, symptomatic carriers, females, and females that have MS. The symptoms are, as I mentioned, urge frequency, but also stress incontinence and the low stream. And like with everything in that's neuro-related, the symptoms of urinary symptoms correlate with mobility impairment. And in fact, from my field of spinal cord injury, if you improve gait ability, you improve bladder ability. And that's truly one of the methods of managing neurogenic dysfunction. There are very well done prospective studies with that. Very low number of people with ALD, individuals with ALD, are treated for urinary symptoms. And as I said, about 2/3 of individuals do report moderate to severe symptoms. That's a nice graph that's very busy from Camille Correc publishing prospective and retrospective chart review studies in 106 individuals with ALD. And if you actually look just to the right side of the graph, you're going to see that in between 60 and 80% of individuals have either one symptom of bladder, bowel, or both incontinence. Bowel symptoms in ALD, mostly constipation, but 10 to 20% of individuals will consider that severe. When and if you decide to look at the bowel and bladder changes as being part of the neurologic disease, it is a good idea not to just see a urologist, but a neurourologist, or somebody that actually does deal with individuals with neurogenic type of bladder. Because truth is that the industry of diapers is over $6 billion, garners over $6 billion a year. So we kind of tend to consider that being, hey, it's just part of the child's life or the adult's life. We somehow go in a circle. We start not being able to walk and not controlling things, and then we get there later in life. But it's not true. It is not true. There are neurogenic cases. There are diagnoses that can be established and then corrected with what I'm going to have specific interventions that are lifestyle, pharmacologic, behavioral, and so forth. So it's good to see a neurourologist or somebody that works in a in a CNS center. Let's put it this way. And of course, there are associated conditions that need to be looked at: diabetes, prostate surgery, depending on where you are in life. A very important thing that I really wanted to put there is the social support is really essential when you're looking at bowel and bladder management options and continence. And then, again, physical examination. When you go to the urologist or a specialist that looks into your bladder function, there is a physical exam that needs to be completed. And I'm sorry to say it, but a lot of people that work in the urologic field will take a very good history, but will not do an exam. Or they will do urodynamics, but that's not done by the physician. It's done in most of the centers. Urodynamic studies are read and interpreted by physicians, but are done by a technician. Not in ours, but that is the reality. Urodynamics are really important because, as I said, ALD has all three types of patterns, and establishing which one is in each specific individual is of utmost importance. It is not a pleasant study, and I'm not going to go through much more than telling you that it does involve a chair that has some stirrups, and it involves catheterization, and it involves pressure monitors that are inserted both into the bladder and into the rectum. Why am I telling you this? To prepare you, because sometimes you, what's that? Thank you. Well, you obviously have the choice of saying, no, I won't do this. But without that information, we do not have a pattern. We do not have your pattern. And right now we're all talking about individualized and personalized medicine. Without doing urodynamic studies, you will not know what your specific bladder pattern is. So, you know, there have been many more other medically induced discomfort times. So this is just one of them. We'll check it to the disease. I'm not going to walk you through this, but we get a bunch of squiggly lines during that. That's why we put all those catheters in. We get EMG, we get flow, we get contraction of the internal sphincter and the detrusor pressure. And then we established these different patterns. They look differently, and that's why it's important for you to have and to be told, okay, this is the treatment you need. So we start with the easy stuff. Bladder symptoms treatment is lifestyle modification, and I can stand here and tell you that this is the easiest, but to tell you the truth, I think that that's the hardest. A lot of people walk in and say, fix me, give me a drug, and I will get to the drug, I will give you the drugs, but every single drug has side effects. So I will bring that into consideration. So lifestyle modification, when I say reduction of fluid intake, doesn't mean, dehydrate yourself. We say around 2 liters of water per day. There are the 8 glasses. There is no real science behind that. What is of importance is follow your thirst. In fact, there is enough science that says that if you're thirsty, you should drink water. If you're thirsty because you're taking a drug that makes you thirsty, which is one of the ones that I'm going to give you in the next couple of slides, you shouldn't drink all that water. You should take other methods because that's a chemically, artificially induced thirst, dry mouth, that are associated with anticholinergics, which are the number 1, 2, 3, 4, 8 classes of medications that are being used for urinary incontinence in everybody. And I'm going to stand here and tell you, don't take them if you have a choice. Don't drink too much coffee. Don't drink too much alcohol. It's not like I'm telling you a lot of things. Carbonated drinks, smoking cessation important, and then the sweeteners are not good. But that's kind of not only just for bladder, but it does help for the bladder, for the fluid management. Use bladder diaries. Everybody's really excited about writing something about their bladder in a diary. So I know that truly, probably in my whole career, and I've been doing this for 20 plus years, I've got one bladder diary. I got like 10 blood pressure diaries, but just one bladder diary. Try to limit the amount of fluids that you drink about 4 hours before going to sleep. If we need to talk about sleep hygiene, that's a completely different talk. If you have the dry mouth, obviously chewing on sugar-free gum, sucking on sugar-free lollipops, whatever. Sips of water instead of drinks of water. And there are some products there, like biotin products, that can help with the sensation of thirst. If there are individuals that are taking diuretics, timing the diuretics, so the next 2 to 4 hours after taking a short-acting diuretic like hydrochlorothiazide or Lasix, furosemide, that would also help with nocturia, with management of frequent going up at night. Time voiding and bladder retraining. I'm just going to mention this because we all do it to our children when we teach them, when we bladder train them. We say, okay, you sit now, and you sit there until you go, and then we're putting them again on the potty 3 hours later and so forth until they achieve continence. That is a method of neuromotor training. It is not, we're creating a reflex behavioral pattern. That can be done as we age too. The same like you can learn how to ride a bike when you're 40 and do all of any motor pattern can be taught at some point or another in your life. You just have to, to put the work in. And the bladder retraining is part of that. I'm just mentioning it because I know that people don't think about it. And it's neuroscience. It's actually not, raising a child. Weight loss is always good. Treat constipation. I have a colleague of mine that said that the poop is at the root of all evil. She's kind of right. And then there are some continence aids, and obviously you've heard about the pads and diapers, but PureWick is a specific system that has been developed for females because guys get all kinds of catheters, but us females don't. So they're expensive, so you don't want to necessarily use those, but it's good to know if you go to a fancy resort and you don't want to look like have one of those diapers with whatever the implantable, I think that was some sort of diaper at some point that made your behind look better. Okay, treatment of constipation, adequate fiber. That doesn't mean that it's the Goldilocks principle. It's not too little, not too much. A lot of people say, oh, hey, it's a lot. I'm eating a lot of fiber. Well, a lot of fiber is not good. Fiber needs water. And so, you're running the risk of being constipated because you're taking too much fiber. I'm getting warm here. Regular exercise, and if I have one take home for everybody is that exercise is the answer, the treatment, and fountain of youth for almost all the ailments to your level of ability. It is incremental. 5 minutes now, 5 minutes later, 5 minutes later. You can still get to 30 minutes in 6 5-minute increments a day. And we look at exercise as being a luxury. It is not. It is part of well-being, just like eating, drinking the right thing does include an old-fashioned every so often. Okay, so let's get to the pharmacologic bladder management. This is just a picture to tell you that each one of the drugs that I will be talking to you about works at a different level of the bladder. And we have oral agents, and we have anticholinergics. They are the ones that help with storage. They relax the detrusor. They give you also constipation. There are numerous studies that are showing the long-term use of anticholinergics increases the risk of dementia. So while it is the number one on my list because it has been used for 20, 30, 40, they have been used, there are like 8 to 10 different drugs on the market, they are my least favorite. And as a word of caution, the ones that are my favorite, if you're going to take an oral one, are very expensive because they're newer, and the insurance company requires you to have trial of 1 or 2 different anticholinergics and fail before they will cover for the beta-adrenergic. So beta agonists, those are your Myrbetriq, mirabegron. That's my favorite if you have to manage your bladder with a pharmacologic agent. It comes in 25 and 50 milligrams. The starting dose in the United States is 25. In Japan is 50. Beats me why. But 25 to 50, there are only 2 doses. It avoids anticholinergic effects. We do not have long-term studies on them, but we also know that one of the things that you should be looking for is hypertension. Alpha blockers, another one that are important in management of neurogenic dysfunction related to ALD, is that it helps with that dysynergia that I told you in between the bladder contracting and the internal sphincter contracting in the same time and increasing the pressures. So this is a medication that relaxes the internal sphincter. It has been used forever and ever in males with prostatic hypertrophy because it helps with that incontinence and urgency. This is the opposite, has the opposite effect of mirabegron or side effect. It can lower your blood pressure. And then cholinergics, very, very little usage. I'm not going to talk to you about that. Let's see, 240. Amen. See, I have all that information. There are some interventional management. You cannot do interventional management without knowing what your urodynamics look like. So I can talk to you about Botox into the bladder. No, it does not help with fine lines, but it does help with continence. It does have a possible side effect of urinary retention and requiring intermittent catheterization. So all of those, the more invasive we are, the more likely we are that we're going to have to manage. That's why you need somebody that deals with a neurogenic bladder in and out. Last comment, there are different considerations for children versus adults because obviously children are in the development phase and their bladder training is still part of growing. I'm just going, the signs are very different. Yes, wetting, but if it's a little one, they wet anyways. They can have urinary tract infections. They can have swollen kidneys as radiographic signs of that increased pressure. And the goals of treatment are different because with children, first, you need to preserve their function. And then as they grow, you're going to go into social continence and finally independence with bladder management. And thank you so very much. This is my group. Thank you all.
Thanks a lot. Great. Questions over there?
Thanks for the talk, Dr. Sadowsky. I have a two-part question for you. So the urodynamics appears to be, somewhat invasive, certainly uncomfortable to go through. Is there ever a need to repeat urodynamics? And can the urodynamics profile change over time? Like, can you go from different class of urodynamic to another one, or no?
Excellent question. Thank you. So urodynamics are good for baseline, then to monitor treatment. Now, if during urodynamics, the initial testing, you do not find high pressures, then you can do monitoring, clinical monitoring. So you start whatever one of those drugs and intervention, and then if they get better, they get better. If there is increased detrusor pressure, then, and you take one of the anticholinergics or beta-adrenergics or Botox or so forth, then you should have repeat urodynamics to make sure that whatever you took is actually doing what it's supposed to. Can the condition, the disease progress to change? Yes. We were just talking about, the burden of disease that can advance, and yes, it could change, especially if you have concomitant central nervous and peripheral nervous system involvement. That's going to throw your testing way off. But it's not so unpleasant. Trust me, there are how many females here that deliver children?
I was wondering if, thank you. I was wondering if you could comment on, in full disclosure, I have one collecting dust at home. They have these personal home trainers now for pelvic floor, like LV. Have your patients had any success with them, or just curious?
Well, success is measured in the amount of effort you put into it. So the dust is not going to do you any favor.
Right. I'm hoping you'll motivate me to, depending on your answer.
I have to say that, you know, I have a better cardiovascular environment, lifestyle now in my 50s that I used to have in my 30s. That's because I did something about it. So just do something about it. And when you have both sensory and motor function, residual, they're helpful. If you have no sensory function, you don't have the sensory feedback for actually biofeedback training, so it's a little bit harder. But you can use visuals to give you the feedback, so you can use pressure monitors and see little.
Yeah, that's what
line.
the app had the few times I
Yeah.
used it. Okay, so you're a fan of that, and
I'm a fan of anything that
Okay.
involves exercise,
Okay.
and that's pelvic muscle strengthening. Is a somatic muscle. It's just like your quadriceps. If you're going to strengthen your quadriceps, it's going to work, you know, help you get time up and go. Is going to go. The test is going to go lower, so it's going to be better.
thank you.
I'm wondering your opinion about, if necessary, an embedded catheter.
If necessary, why? Because because of frequent or
Frequent and inability to use a catheter on your own.
to catheterize.
Yes.
Okay, so you already need to empty your bladder.
Yes.
Yes, so there is a rule of thumb for infection prophylaxis. The best way is intermittent catheterization that you do on your own. The second one is intermittent catheterization that is done by a caregiver. The third one is a suprapubic catheter, and the fourth one is a Foley. Those are in order of likelihood of recurring urinary tract infection. Behaviorally, it's your decision. There are people that, you know, will just have to deal with the Foley. But anytime you have a catheter, I just told you that the bladder is not sterile. Every time you have a catheter inserted or staying in there, you increase the risk of bladder colonization.
Last question.
How often do you recommend self-catheterization per day?
How much you drink. The typical bladder capacity should be around 300 to 400. If you're a nurse that works the night shift, it's 2,000, but that's something else. So 300 to 400. So if you're going to drink 2 liters, 1,800, 2,000, you know, it's 6 to 7 times a day. If you're going to drink more only during the day, you might need to do it a little bit more frequently, every 3 to 4 hours during the day, and then at night you stop the 4 hours before going to sleep, and you won't need to get up, hopefully. But what goes in must come out. Thank you.
Thank you. Thank you. You can ask her.